Hello, welcome back to my channel. My name is Gia. I'm your friendly family nurse practitioner. And today I am so excited to talk to you about chronic headache because chronic headache is very common in primary care. And so when patients describe their symptoms, it's natural to worry about serious causes like stroke or tumors, right? And also, it's not just us. Patients themselves can feel scared because chronic headache can really disrupt life, and it can cause debility and can cause to missing work too. And by the way, I use 5-minute consult and my experience as a reference to this presentation. And so I'm here to help you feel more confident in handling patients coming in for headache. You know, they often come in seeking answers, and they always wanna ask for imaging, but understanding the common types of chronic headaches can guide you in recommending the best path forward for them. I hope that by the end of this presentation, you feel more confident and comfortable in navigating headaches with ease and provide reassurance and effective care to your patients. So what is chronic headache? It is defined as prolonged headaches lasting more than 4 hours, occurring on 15 or more days per month, so more than half of the month, for more than 3 months in the absence of organic pathology. Okay, so what are the red flags that you need to consider if your patients are coming in for chronic headache? So if the patient, these are the red flags, guys. So if a patient is 50 or more at age of onset. So this patient never had headaches before and they're 50 years old and now starting to have a headache. That's a red flag. This one, acute onset thunderclap headache. Okay, characteristic of brain aneurysm. New headache. Significant change in the characteristics of prior headache. Signs and symptoms of systemic illness like fever, nausea, vomiting, chills. Neurological symptoms not consistent with typical aura symptoms, and non-systemic illness that predispose to secondary headache like sinusitis, hypertension, ear infection, post-concussion syndrome, and headaches associated with maneuvers that increase or decrease intracranial pressure. Okay? Alright, because of the red flags, you are going to order CT of the head without contrast or MRI because we want to rule out the serious causes of headache. Okay? So history is everything. So you're going to want to know the onset, duration, location. Characteristic is important. Aggravating, alleviating. So what are the medications? Are they helping? The timing, any trauma, any previous history of headache. You want to know if they have a history of migraine, cluster, tension type, and systemic symptoms. So make sure you check for fever, neck pain, rigidity, rash, it's rash, dizziness, neurological deficits. Okay? For physical, you want to do neuro, head, ears, nose, and throat, and eye exam. So, if your patient's coming in and describing their chronic headache as it's been going on for 3 months, it's happening more than 8 days a month for at least 3 months, and it's only on one side usually, and it's pounding, throbbing, debilitating, and activity aggravates their headache, and it's associated with nausea, vomiting, phonophobia, photophobia, with or without aura. Okay, can you guess this type of a headache? This is easy, right? These are the characteristics of chronic migraine. So what do you think you can recommend for treatment and lifestyle changes? So pharmacological rescue or abortive treatments. So the rescue medication are more effective when given earlier in a headache. For mild or moderate severity, you can use NSAIDs plus antiemetic. I actually have a patient that is very well controlled with this regimen. And then if they're coming in for moderate to severe, I usually start with triptans. But remember, guys, what are the contraindications to triptans? So ischemic heart disease is a contraindication, stroke, uncontrolled hypertension, transmittal angina, ischemic bowel disease, and peripheral artery disease. So these are cardiovascular diseases, okay? So do a due diligence in asking your patients about their past medical history before starting them on triptans. Prophylactic medications, there's actually a guideline or criteria for when you start your patient on prophylactic medication. For me, though, I ask my patient if is your headache that severe that you are willing to take a daily medication to reduce the severity and intensity. And if they say yes, then I'm going to start them on these medications, the anti-epileptic drugs, beta blockers, TCA, and actually you can do naproxen too. I ordered propranolol to Paramate. I've seen providers ordering that too, okay? And so if the patient's having resistant migraine, and even with these medications, their symptoms are still persistent, you can refer them to neurology for the injection of onabotulinum A. Okay, lifestyle, you want to recommend sleep pattern regulation, so diet, exercise, weight loss, and reduction of caffeine intake, and physical therapy, acupuncture, biofeedback, relaxation therapy, and cognitive behavioral therapy have also been shown to be helpful. All right, let's move on. And so if the patient coming into you and they will say, Gia, my headache has been lasting hours with at least two of these characteristic features. It's pressing, tightening in both sides of the head. It's not aggravated by activity, and only one photophobia or phonophobia, so only one of this, with mild nausea. What do you think is the culprit of their headache? It is called chronic tension type headache. You knew it. So what are we going to do? What can we recommend for patients with chronic tension type headache? So these are the medication, right? You can start them on Tylenol, the NSAIDs. Again, make sure that you want to assess for any contraindications of NSAIDs, such as history of GI bleeding, chronic kidney disease, coronary artery disease, history of MI, and caution if the patient has hypertension. And you can also do prophylactic medications, but I think with tension type, it's a little bit harder to control. I mean, the prophylactic medications are a little bit less effective as with compared to chronic migraine. And if they're resistant to, you can refer them to neurology for the injection of onabotulinum A. And recommendations as far as lifestyle and other modality to help with the headache are the same as with a chronic migraine. Okay. What about if your patient presents to you with new daily persistent headache, and it's developing within 3 days and has been ongoing and unremitting for more than 3 months? What are you going to do first? I would order neuroimaging, either CT of the head or MRI. And then if the CT or the MRI does not show any concerning features, then you can proceed to recommendation either chronic migraine or tension type headache. All right? Okay, so what if your patients come in, oh Gia, I'm having this daily continuous strictly unilateral primary headache that is associated with these cranial autonomic features. They're saying that they have meiosis, ptosis, eyelid edema, and lacrimation with nasal congestion and rhinorrhea. Can you guess? This is called hemicrania continua. Okay? And your treatment recommendation is indomethacin. So typical starting dose is 25 milligrams 3 times a day. And again, make sure you rule out, the contraindications. I do want to mention that, the hemicrania continua could sound like a cluster headaches, right? But cluster headaches typically occurs in clusters with frequent intense attacks lasting 15 minutes to 3 hours. And they're often accompanied by autonomic symptoms too, just like hemicrania continua. The pain is strictly unilateral with cluster headaches, focus around one eye or temple, and may involve the face or the neck. Hemicrania continua, on the other hand, presents as constant unilateral pain with occasional exacerbations without distinct remission periods. Okay? With cluster headaches, they have remission for months or years. The pain location can be similar to cluster headache, but tends to be less severe. Hemicrania continua will respond to indomethacin, whereas cluster headaches are managed with various medications, including oxygen, and you can also help the cluster with triptans. All right. So what about when your patients come into you and present to you with persistent headache, and then when you ask them what medications they're taking and how long they've been taking, they say, oh yeah, I've been taking triptans for more than 10 days a month on a regular basis, or other non-opioid analgesics for more than 15 days a month, or a total exposure of all acute drugs more than 15 days a month. What do you think is happening here? So your patient is experiencing medication overuse headache. So treatment for this is just withdrawal of offending agent. And you can consider initiating preventive agent if the patient's not taking yet. But some providers can make the patient, alternate between the medications used for the headache. But this is actually a little bit more challenging to manage. A rare and severe case, I've heard some patient can get hospitalized to help with transition, with the withdrawal, but I haven't actually encountered this in primary care. All right, guys. Thank you so much for watching, and I hope you found this presentation helpful. Remember, I'm your friend and mentor, and please subscribe to my channel if you like this video. And I'm sending you lots of positivity and encouragement and motivation to continue what you're doing, and you are doing wonderful. Bye for now.